Good morning. Good morning. We got about 4 minutes before we're going to start. So get your beverage ready. Good morning, everyone. We will get started. And I've got 10 o'clock. Good morning, everyone. It is June 3rd, 2026, I believe. If you are looking for the long-term services and support that's going to be on video subcommittee, you're in the right place. I am your chair, Matt Seeley. I wish I was there in person, but there are good days, there are bad days, and there are disability days. Today is one of those days. And if you know what I'm talking about, then you know what I'm talking about. If you don't know what I'm talking about, then I wish you did, then services would probably be a lot better. But that is where we are. Pam, are you with us?
Hi, Matt.
Good morning, Carol. How are you?
Okay, I know. Forgive me about one of those days. Believe me.
You know those days too. I know, Carol.
Hi, and Matt, this is Pam. I am here. I was just struggling to get unmuted.
You can take it from here, Pam.
Okay. All right. I think that our next is roll call. So Matt, I know you're here. Abigail Foster. Abigail Foster. Oh, and if people could let me know also if they're in the room or not. Andrea Costello.
I'm here in the room.
Oh, great. Okay. Anna Warheit.
Good morning, this is Anna joining virtually.
Great. Carol, I know you're there. Are you joining virtually or are you there?
Virtually.
All right, thank you. Neil Brady. Ginny Rogers. Jay Harner.
Good morning, virtually.
Thanks. Kathy Cubitt.
Good morning, this is Kathy. I'm joining virtually.
Okay. Laura Lyons.
Good morning. I am joining virtually.
Great. Linda Litton. Lloyd Wirtz.
Present, taking up space.
All right. Taking up space in the room?
Yes, it does.
Yes,
Okay.
Lloyd Wirtz is in the room, Pam. I'm just going to go through Andrea Costello and Shel Garrett and Ryan Johnson are also in the room with me.
Okay, great. All right. Okay, Lynn Widener.
Good morning, this is Lynn. I'm joining virtually.
Michael Galvan. Shel Garrett, I know that you are there in person. I'm going to pronounce this badly. Padraig Tangney.
Hi, Pam. This is Paula. Padraig is here.
Okay, great. Natalia Gomez.
Is that Nathan Lampenfield? Would you mind muting your microphone? What's that noise?
Yeah, it sounds like wind blowing. Someone's maybe outside.
Yeah, I apologize, Nathan.
Matt and Pam, I believe that might be the HVAC system in this room. Sometimes it does cause that difficulty, and unfortunately, we've checked with building maintenance, and it's not an issue we can resolve.
Okay.
Okay,
All right.
fair enough.
Good to know. Natalia Gomez. Oh, I don't know if people can hear me. I seem to have lost sound.
No, that noise stopped. You're fine.
Oh, it's just the noise stopped. Okay. Natalia, are you here?
She's not.
Okay. Rebecca McTaggart. Ryan Johnson.
I believe he was.
Has anyone else joined since I called the roll? All right. I think
that's what the issue is. When you guys unmute in the room, that's when we hear it.
Yeah, because it did go away for a moment, and it's gone again. Yeah.
It's Shenrika's mic. That's the one that's causing it.
Okay. All right. I'm going to read the housekeeping talking points. This meeting is being recorded. Your participation in this meeting is your consent to being recorded. The meeting is being conducted in person and as a webinar. To comply with logistical agreements, we will end promptly at 1 p.m. To avoid background noise, please keep your devices muted and the microphones off unless you are speaking. If you are attending the meeting in person, please keep background noise to an absolute minimum. The room is fitted with ceiling microphones that pick up everything. One of the chairs will report in-person attendance. Remote captioning is available at every meeting. The CART captioning link is on the agenda and in the chat. It's important for only one person to speak at a time. Please state your name before commenting and speak slowly and clearly so the captionist may capture conversations and identify speakers. Please keep your questions and comments concise to allow time for everyone to be heard. Webinar attendees may submit questions and comments into the questions box in GoToWebinar or use the raised hand feature to be put in queue to speak live. Those attending in person should use one of the microphones and wait to be called upon to speak. The tabletop microphones are reserved for committee members. Microphones are limited, so you may want to wait for OLTL staff to bring one to you. The general public should use the microphone on the stand in the rear before the committee tables, in the rear of the committee tables area. OLTL staff are available for assistance. Before speaking into a microphone, use the power switch on the top middle of the microphone body to turn the microphone on. The switch should be pushed toward the end of the microphone you speak into. When you're finished speaking, push the same button toward the bottom of the microphone body to turn the microphone off. Time is allotted on the meeting agenda for 2 public comment periods. If you have questions or comments that were not heard, please send them to the resource account email found at the bottom of the meeting agenda and on the LTSS Subcommittee page. In the event of an emergency or evacuation, everyone must leave the building and assemble in the First Responders Plaza. OLTL staff will be available in the safe area in front of the elevators to provide any assistance. If you're there in the room, please see the back of the agenda for more emergency evacuation information. And I think that's it.
Okay. Thank you, Pam. On to you, Juliet.
Great, thank you. Is the noise back now that my microphone's on?
No, not really.
Okay, good, very good. All right, have a little bit of an agenda today for my updates, so we can get started. We'll do the usual procurement updates. I'll talk a little bit about assisted living in lieu of services, some of the proposed rulemaking that we've received, in particular provider revalidation, state-directed payments, and targeted Medicaid practitioner payments, and just a quick review of OLTL communications at the end. And certainly we'll have the HR1 team do their update and then go into public comment. So the next slide, we have some new news with the procurement update. So on June 1st, we canceled the RFA for the reprocurement of the CHC program. We have also on June 1st published a request for information that is on the PAE marketplace. So we are seeking information to assist us with suggested input and information concerning the current CHC agreement, which is posted on our website, for an anticipated reprocurement of the CHC managed care organization in the CHC program. So anyone interested in providing feedback and comments can do so by July 15th, 2026. And that is by submitting them to the email address as noted on the RFI. If you have questions regarding the RFA that was canceled, that email box is still open for a little while. So you can send any questions about the canceled CHC RFA to the RA-PW-RFA-questions@pa.gov. That's for the old one. All questions regarding the request for information that was posted should be directed to a different email address with procurement's team, and that is RA-PW-RFI-comments@pa.gov. So certainly encourage everyone to take a look at that and encourage folks to submit their comments as directed in the RFI. It also means we are in a blackout, so please don't send comments to us. Please send them into the RFI comments account.
Juliet.
Yes, Matt.
Just a quick question about that, and not any particulars, but just for the average participant, what does this mean for them?
So this means that the current CHC program will continue to operate as it has been under the current CHC agreement until such time as a new procurement occurs. So for the average participant who's utilizing services, it means they should expect no changes to the day-to-day operations as we routinely have done since inception of CHC. All right. Good question, Matt. Thanks. I should have added that. Okay, so if we go to the next slide, moving into assisted living within lieu of services options, just wanted to give folks an update. So in effective January 2026, all three of our Community Health Choices Managed Care Organization partners submitted and received approval from us to offer the assisted living in lieu of services option. And I know in past meetings we've had lots of presentations about what that means and how that runs, but we wanted to give you an update on the progress. So currently there are 18 assisted living residential providers enrolled for the in lieu of services option. In the 2025 calendar year, because the HC runs on a calendar year, we had 15 participants choose to utilize the assisted living in lieu of services option. In quarter one of calendar year 2026, so that's this calendar year, the CHC MCOs collectively reported that 13 additional individuals chose to use and is selected to receive assisted living in lieu of services as an option for their services. So this is almost doubling the total number of participants utilizing the option in just one quarter as compared to the last year. A lot of that is probably due to the increase in education, availability, understanding, and kind of getting through some of the operational processes a little faster than when we first implemented it. So out of the 28 participants currently participating in assisted living in lieu of services, just to kind of bear in mind, each MCO can develop the program differently. This is not a program that OLTL designs and puts out. This is a program that CHC MCOs can choose to develop and put forward in this category of flexibility as an in lieu of service. So out of the 28 participants currently participating in an assisted living in lieu of services option, 12 individuals were transitioned from a nursing facility directly to an assisted living resident, and 16 individuals were diverted from an impending nursing facility admission. The Office of Long-Term Living, since this is new, has engaged the Medical Research Center, MRC, out of the University of Pittsburgh to assist in completing an independent satisfaction and experience survey of the assisted living in lieu of services participants and providers as a means to assist us with monitoring the implementation of the program, the services, and the impact. And we, the team here, continues to provide education guidance and support to all partners through our regular meetings, through outreach efforts, technical assistance. We certainly encourage more of the assisted living residence providers who might still be a little anxious about dipping their toe into our Medicaid enrollment program to please consider enrolling so we can build out that network for coverage across the Commonwealth. So if folks are interested in learning more about assisted living in lieu of services, if we go to the next slide, my team has prepared a list of resources kind of commonly available with a lot of information for folks. So if you are interested in the policy pieces, we have the Long-Term Care Handbook from the Office of Income Maintenance Policy, Chapter 490, that was released January 7th, 2026. There is the In Lieu of Services Operations Memo from the Office of Long-Term Living that was released back in October of 2023. And the Ops Memo number 2026-04 related specifically to the PA 1768 change form, which was released in March of 2026. So if you're interested in sort of some of the policy stuff behind it, some of the details and how it operates, et cetera, these would be good resources for you. In addition, it's also included in the CHC agreement. If you have specific questions regarding assisted living in lieu of services option, please direct it. If it's a participant question related to participant services, please direct that specific question to the CHC MCO that is serving that participant. General questions about assisted living can also be sent to our Pennsylvania Independent Enrollment Broker. Their team has been trained on assisted living in lieu of services option, and or questions can be sent to the Office of Long-Term Living's Provider Enrollment Unit, particularly for those assisted living providers who have yet to enroll and might have questions or need support. The OLTL team is ready to assist you there. I would say, as an important caveat, that the assisted living in lieu of services is not available to anyone in an assisted living residence. You can't just say, oh, I want assisted living in lieu of services. Assisted living in lieu of services is a service that is available to individuals who are eligible for this Community Health Choices program and long-term services and supports. You have to be a CHC enrolled participant with a CHC MCO before enrolling or selecting an assisted living option. There's always some confusion with that, so I hope that helps clear that up. All right, if we go to the next slide, I'm going to switch and talk a little bit about provider revalidation. So we, as many know, received on April 23rd, 2026, a letter regarding the request for states to develop and submit a comprehensive 2-year provider revalidation strategy. This came from CMS. And this was to include a description of how Pennsylvania ensures the accuracy of our provider enrollment data through revalidation and other approaches. We have been analyzing that letter and that request and speaking amongst all the different offices, because it's DHS-wide, to finalize the response. The response is being finalized, so I don't have specifics to share with folks today, but certainly DHS, in the Secretary's office and the exec team will be sharing additional information once that response is finalized. In that response, I'm talking about the 30-day expansive response. There was a 10-day response as well, which we did respond back to, and that is simply an acknowledgement of the letter. So we did that. We said we received the letter, and now the 30-day response is in being finalized. What I would say there also, since we're talking about provider revalidation, is I encourage all providers to take a look at your provider revalidation date and promise, and to be very timely on your revalidations. You've heard me talk about this before, but if you let your revalidation lapse, that means you are out of the program. You will not get paid. It's not retroactive. If you let, for folks who are licensed by the Department of Health, if you let your Department of Health license lapse, then you are out of the program. There is no retroactive payment because there's no retroactive licensing reissuance from the Department of Health. These are very important dates and activities. Please stay on top of them so we can maintain a robust provider network. All right, let's go to the next slide. Now I'm going to be switching to the Medicaid Community Engagement Requirement Interim Final Rule from CMS, which is document CMS-2454-IFC. So on June 1st of this year, CMS released an Interim Final Rule, or IFR, requiring that certain adult Medicaid applicants and enrollees must, as a condition of Medicaid eligibility, meet an 80-hour per work requirement through employment, education, work programs, or community service. The rule also includes state data reporting requirements and establishes requirements for how states must assess and verify compliance and communicate the new requirement to Medicaid applicants and beneficiaries. A fact sheet, condensed version of the Medicaid Community Engagement Requirement Interim Final Rule. We included a link to that so that folks can access that fact sheet or be directed to that fact sheet that was posted by CMS. CMS has requested public comments on this interim rule. Let me say that again. Any member of the public can submit a comment to CMS on this rule about community engagement that they are putting out there. So interested parties can submit their comments through the Federal Register And we have included a link for that in our programs, but you can certainly go to the CMS website and find it there. This is very connected to our work around HR 1 and the Medicaid expansion, community engagement / work requirements. So I will reiterate, any member of the public or any stakeholder can submit comments to CMS directly about this interim final rule, and those comments are due by July 31st. All right, another proposed rule, if we go to the next slide, is on state-directed payments and targeted Medicaid practitioner payments. So back in May of 2026, CMS released a proposed rule for public comment describing alternatives to modify the limit on the total payment rate and other requirements for state-directed payments and Medicaid managed care. So what's a state-directed payment? A state-directed payment is where the state, us, can direct how certain funds are distributed through some of our agreements in CHC. For the Office of Long-Term Living specifically, this is really part and parcel with our nursing facility rate process and our nursing facility assessment process. All right, so it's a pretty big deal for CHC. So the proposed rule addresses requirements pertaining to prepaid inpatient health plans and prepaid ambulatory health plans, requirements pertaining to contracts between the states and managed care organizations, like our agreements with us and Community Health Choices, to provide payments under a risk-based contract for services and associated administrative costs that are actuarially sound, changing kind of how we report things. It sets a limit for certain targeted Medicaid payments and the Medicaid fee-for-service, and CMS is accepting comments in the proposed rule for 60 days with the comment period ending July 21st, 2026. Interested parties can submit comments via the Federal Register. It's fairly easy to do, so we encourage anyone, because anyone can submit comments directly to CMS, to take a look at that and submit comments if you so choose. OLTL communications. So we had some recent communications go out. Just a reminder, our 2026 Nursing Facility Quality Incentive, NFQI program attendance list went out in May, so on May 19th via our listserv to nursing facilities. We released who we had on record for attending the trainings through the Long-Term Care Learning Network webinar. We also included the attestation form that's required for 2026. Take a look at the list. If you are not on the list and you believe you should be on the list, please submit the attestation form. And if you have any questions regarding attendance or the attestation form submission, please send them to the following resource account, RA-PWNATPEST@pa.gov. Webinars for the 2026 NFQI are currently occurring on Thursdays at 2 p.m., and you can find more information and links to those webinars at www.tomorrowshealthcare.org. So for our nursing facility folks, we do encourage you to participate in those. So now I'm going to hand things over to Pam and Lloyd for the HR1 updates. We're going to hold questions for me or comments for the public comment period that will immediately follow. So Pam, back to you.
Okay, great. Thank you. This is Pam Walls. Lloyd, would you like me to start since you're a little bit newer as our liaison?
Sure, go right ahead.
All right. So again, I am our LTSS, one of LTSS's liaisons to the HR1 implementation stakeholder group. It's a series of meetings that the department is holding with stakeholders to get feedback and tell us about how they are implementing the requirements of HR 1, also known as the Big Beautiful Bill. And Lloyd Wirtz is now our second liaison to the group. We had a stakeholder meeting on May 8th. The PowerPoints from that have been distributed, I think. It focused on, first of all, I just want to say that the Secretary Arkush began by telling people that they are very focused right now on implementing community engagement requirements, which I'll talk about a little bit more in a second. But there is currently no, work going on that would reduce benefits, reduce eligibility, anything like that. We're just not at that point in the process yet. And in fact, she said that she is hopeful that anything like that, if it ever does come to pass as a result of HR 1, wouldn't happen until perhaps as late as maybe 2029. So just as a reassurance, for starters, the department is not working on figuring out any kinds of cuts to programs currently, and doesn't seem to foresee doing so anytime in the near future. So the PowerPoint, the rest of the presentation went through the work that the department is doing around implementing community engagement requirements, which go into effect in October. And as a reminder, the community engagement requirements, also called work requirements, they only affect the Medicaid expansion group. This is, Obamacare or MAGI, people who became eligible for Medicaid after the Affordable Care Act and when Pennsylvania adopted that option. So it does not apply to anyone, I think, in community health choices, because those populations are, as they are defined, are just not included in this. So the population we're thinking about are adults between the ages of 19 and 64. And so we heard about the department's plans for implementing the community engagement requirements, including a lot of information on the approach that they're taking, which involves using electronic data that they have to the greatest extent possible to determine whether people are in compliance because they are working enough hours, and also to determine whether people meet various exemptions, which means that they don't have to comply with the work requirements. So having said that, people in CHC are not going to be affected by this, we are aware that a lot of people in their lives will be family caregivers, direct care workers. The population also includes a lot of people who have health issues and disabilities, but are not getting SSI or Social Security disability. We also had a demonstration of the work that the department's doing on Compass to start to enable people to input information about their work, their other community engagement, or whether they meet criteria for exemptions. So there was a demonstration of that. So after that meeting and all the materials that were released, the department asked stakeholders to provide feedback by May 31st. And so we had an ad hoc meeting, as I hope most people know, of the LTSS last week to present this in more detail and to gather feedback. I think that feedback has been shared, and if not, we will. It just to go through it quickly, a lot of the concerns were around the importance of DHS having enough staff to implement this, because it's going to require a lot of verification, a lot of touches on people's cases. we made a number of recommendations, including that information be used to cross-check whether people are in compliance or exempt with information that a verification that's been gathered for the SNAP program. We had a question about whether HR 1 will affect people in the MAUD program. And we also provided a lot of outreach, a lot of feedback on outreach letters that the department had released. So the department released draft outreach letters that they are planning to send to people who will be affected by the community engagement requirements. First of all, a general letter telling people that this is coming, and then later letters telling people that they need to comply or they're not in compliance and how they can be in compliance. And so we had a lot of feedback, as I know a lot of other people who gave feedback did, about the readability, making sure that these letters are written at a 6th grade reading level, and to avoid terms that are, sort of needlessly complex. We had some specific recommendations around clarifying some of the language that was a little bit vague and confusing. Also, one of the forms had a list of different criteria which would make someone exempt from the community engagement requirements, like being a caregiver to a person with a disability, or being, having certain medical conditions. It's a fairly long list. We recommended that the list be reordered so that the more common ones be put at the top of the list. So just in case people don't manage to read all the way through a fairly long list. We also had some recommendations around making sure that there are translations that are done for the language the LEP populations. And we had some volunteers who asked to review draft letters in Spanish translation. So that is most of the recommendations that we submitted formally. I was just going to also say that that the interim and final rule was released by CMS. Juliet just covered that. Public comments, as she said, are due July 31st. And people are really going through that rule, and it addresses how the state will implement community engagement requirements. And there are going to be a lot of webinars for people who want more information about it. National Health Law Program is doing one tomorrow, so watch for those. And then finally, the next stakeholder meeting is July 14th, and we will report back after it. Lloyd, what do you want to add?
Was Lloyd adding anything?
Lloyd, are you there?
Yeah.
Oh, hi.
Lloyd is
I'm
here.
sorry, that was a
People on the
lot.
street can hear me.
Oh, sorry. Now we can hear you.
Is it working?
Yeah, now it's working.
Okay. Well, then I can get to say that again, because the pure intentions, from my opinion, is that the effect of HR 1 is to balance an unstable and unbalanced federal budget on the shoulders of the most disabled in our Commonwealth and across this nation. That's the reality. However, those same folks and their advocates, including myself and many people in this room, need to create recommendations and comments that can be filtered through Pam and myself to the work group that can be understood and are well thought out from your perspective. I don't have that. I'm not sure Pam has that. So we really need to have those comments and suggestions delivered to us. And if you decide not to do that and we reach the end of this thing and we're all wrung out and everything is tragic, get a mirror, because you'll be looking at the person responsible. We need to hear from you as to what type of questions and what needs we have to address at the DHS level and eventually, hopefully, to address at the federal level. There's one question in my mind, and that I believe is there was a response sent to CMS that has not yet been shared publicly. Am I off with that, or am I wrong with that?
Which response is
You're
that,
not off
Lloyd?
with that.
There was a letter sent by DHS to CMS in response to their initial issues, I believe, and that has not yet been shared publicly.
So there's two for the revalidation piece. There was a 10-day response letter, which was essentially us saying, we got your letter. You've asked us to say we got your letter. We've got your letter. And then there was a 30-day response plan, expansive letter. That second response is under final review.
Okay, so there are apparently two letters that are eventually going to be shared?
I mean, the details of the letter will be shared. I can't say what the final contents would be because I'm not the lead on that.
And I'm also, since I haven't not yet attended a work group meeting, I don't know if there are any providers on that group. Because I heard a presentation yesterday from behavioral health providers that they're either limited or very few.
So just to go over who's on the HR1 informational committee, there are two representatives from every Medicaid advisory committee and subcommittee. So that's two people from the MAC, which is seen as the steering committee. It's two people here from LTSS, Lloyd, you, and Pam, two individuals from the Medicaid Service Delivery System, two individuals from the IMAC, two individuals from the Consumer Sub-MAC. I apologize, I might be missing some folks. There were a limited number of individuals that were also added from non-Medicaid advisory groups for very specialized groups that are not typically connected to the Medicaid advisory groups, and from like the child and youth or folks and things of that nature. But otherwise, there is expansive representatives, and we tried to make sure that there was expansive representatives within the MACs. Each subcommittee kind of decided their own way, right? We had volunteers, so I appreciate the volunteers, but there are from Provider Association, Richard Edley is there, so that represents, RCPA when, they have providers and.
But that's the association, not the provider. That's the question I'm asking. Are there actual people who are in the trenches doing the services who are represented on that work group or not?
I believe there are. I would have to go back to the list, and I can certainly ask Catherine Stetler to maybe publish the list. But the charge of the HR1 committee is, again, also like what we do here. Those representatives are charged to go back to all their stakeholders, both inform and collect and get that feedback. So as any, like Richard Trade Association would do, he would go back to his X hundred number of providers and say, hey, this is what's going on. Give us your thoughts.
Well, that's good, because I gave the same stuff I gave today at the RCPA board meeting yesterday. I don't know if they're ready to hear it or not. But anyway, the more impact we get from folks who are in the services and providing the services that we can then detail and share at this work group, the better our lives and the lives, of course, of our consumers will be. Thank you.
Thank you, Lloyd. It warms my heart, really, to hear that stuff. The reason we have HR1 is because none of these people in government hear from us anymore. Here's an opportunity. We're asking for comments. Give us your comments. Give us your feedback.
Yeah, thank you, Lloyd. That's really important context. We get into the weeds and forget where this all came from and what it means.
You want to start with public comments, Paul?
Do you want us to start in the chat, Matt?
Well, I mean, do you want to start with panelists first? I don't know. We called it public comments.
Sounds good. We can do that.
Do any panelists have questions? Go ahead, Lynn.
So Lynn Widener has her hand raised from the committee.
You didn't hear me? I said go ahead, Lynn.
Sorry, no, I didn't hear you. Actually, I just wanted to make a comment and appreciate the op-ed that was published in May by the Secretary to explain the extensive, like the process the department uses to prevent Medicaid fraud in the Commonwealth. But I was also wondering how the department is approaching the threat of investigation in Pennsylvania's Medicaid system, like we're seeing in Minnesota and California, given how those investigations seem to be do not seem to be based in good faith attempts to actually prevent fraud in the system. Can you give us like insight into ways the department might be prepared to defend the Medicaid program beyond just like the traditional anti-fraud measures that we already know about?
Thanks, Lynn. I appreciate the comment and the question, and I do hope a lot of folks take a moment to read Secretary Arkush's op-ed about program integrity. Every program integrity process, procedure, operations always has room for continuous improvement. As soon as we figure out a scheme that's going on, schemers be changing, right? And so it's an ongoing process. I think Pennsylvania, we are very proud of our program integrity process. We have the highest conviction rate in the nation in terms of pursuing those that would commit fraud within our programs. We have a lot of data analytics that we utilize and leverage. EVV, electronic visit verification, is a big component of that, for instance, in community health choices and our long-term services and support programs. It provides a lot of data to help us monitor and identify and elevate situations. We certainly do a lot of retroactive review of claims encounter and other data. We have a very, I think, robust public awareness campaign. If you see something, say something. We take all of those tips very seriously within our programs. For the Office of Long-Term Living, as is with my sister offices, we have very strong systems and coordinations and requirements in our agreements with our health partners. They have very strong integrated kind of vertical processes within all of their organizations to take a look at things, to flag spending or circumstances or patterns that they see that would raise alarms. We have a very high percentage of referrals to our Medicaid investigative unit, our Bureau of Program Integrity unit. So I think in Pennsylvania we have very sophisticated processes, but certainly we always have room to continue to innovate, to continue to do better, do more, and do it faster. Unfortunately, there will always be individuals and systems as large as ours that would be looking to take advantage of it because, there are billions of dollars in our system. So it will always be a target. And so we always rely on everybody within our systems to be part of our program integrity process. So I don't know if that answered your question, Lynn, but it's the best I could give for today.
Thank you.
Kathy?
Thanks, and thanks for all the information.
It's hard to hear you, or is that just me?
I'm sorry. I'll speak a little louder. Just again, thank you for all the information shared today, and also for convening this for the committee to be able to submit comments around HR1. I have a quick question regarding the assisted living and rural services.
I'm sorry, Kathy, we cannot hear you very clearly. There's either feedback or it sounds like you're far away from the microphone. I'm so sorry.
Okay, I'll put my phone
don't know if you might want to try using a different means to perhaps call into the meeting because it really is coming across pretty garbled. Matt, it looks like she might be trying to log in a different way. Might I suggest going to public comments in the interim?
Sure. Unless, is there somebody in the room that has a comment?
Nope, no raised hands
Right.
from the committee members, unless you want me to have folks come in from the audience. There are raised hands in our audience from the public.
Sure, go ahead.
All right, Linda?
Oh, do I have to come up there?
Yeah.
I have a big mouth.
Well, it's so our captioner can hear easily, and then if I can have a staff member. Thank you.
Hi, my name's Linda Anthony. I'm actually just the consumer of services. So I wanted to say to you, I hope that either that online and whatever handouts you give, you are giving people some explanation of HMO, DMO, CTO, and all the abbreviations that we use in this business, because I haven't been here for a while, and there's new abbreviations, and I was getting kind of lost. So if you want to get public comment and you want them to understand what it is you're trying to get from them, you're going to have to make this a little more consumer friendly and make sure that online there's an ongoing active abbreviation list, and any that you use should be added to that list. So that's just one thing that would help consumers, I think, to try to understand this process. And I would hope in your consumer subcommittee, the stakeholders meeting, I don't know what that consists of now, but I would think that's the place. Anyway, I appreciate the time. Thank you.
Thank you, Linda. I believe, and my staff can correct me if I'm wrong, whenever we send out the sort of documents in the packet, we do have a list of commonly used acronyms in our wonderful alphabet soup. I certainly will always endeavor to try and not revert to the acronyms as much as possible. So thank you for keeping me honest on that. And I do agree that we have some new acronyms on there that perhaps can be added. So I'll have my team take a look at that so we can add some new ones like HR1 for that House Resolution 1, the budget bill, et cetera, and work on doing more of that to help prepare and educate our participants. So great comment. Thank you.
Thank you.
We have some additional in the room.
Go ahead.
Me? Okay. Yeah, this is the first time I've been here. My name's Patrick Driscoll. I belong to Community Health Choices. And I'm here to find out how I can get into long-term living. I had a concussion when I was 3 years old. I failed first grade. I went to school through the
Yeah, you want to be out personal information here.
Oh, okay. Yeah, like I said, I had a concussion when I was 3 years old, and I belong to Community Health Choices, and I'm interested in trying to get into long-term living. My seizures were controlled pretty much by medicine. What?
I'm so sorry to interrupt you. Matt, our chair, wanted me to kind of remind you that if you're asking for assistance in getting into the services, what I'm going to do is have a staff member talk with you, because there are hundreds of people on this call. It certainly is up to you.
That's fine.
to share your story, but
I can do that after the meeting. That's
Okay.
fine.
Okay, great. Thank you.
I just we wouldn't want you to have to share personal information in front of all these people. Is there another question in the room? Juliet?
I don't see any other indicators of public comments from the room.
Paula, I don't. There's no other hands on the committee.
Yeah, I understand.
Hi, Matt. This is Paula.
Go ahead.
I have a question from Jody Ricketts. Will consumers who go with assisted living but then decide they want to live in the community, for example, an apartment of their own, would they be able to get NHT to assist, or what service will be available to assist consumers?
Hi, Jody. That is a great question. So to answer your question, in the Community Health Choices program, where assisted living residence is available as an in lieu of service, one of the home and community-based services is community transitioning supports. And I'm just going to read the definition for you. So community transitioning, which is available to any individual who receives home and community-based services, provides services for one-time expenses for individuals transitioning from an institution, and this is a key thing, or another provider-operated living arrangement to a private residence where the person is responsible for his or her own living expenses. Now, these are one-time. They have lifetime limits on them, so it really depends on the individual. And so for a member who's in an assisted living residence, either by in lieu of service or by other means, who is eligible for HCBS, that benefit is available to them, and they should be asking their CHCMCO plan about that benefit, any limits that they've had previously, or any additional benefits that the Community Health Choices Managed Care Health Plan might have in that category, because some of the health plans go above and beyond the minimum benefit. So I hope that answers your question. It's really going to be individualized based on the person and their health plan.
Hi, Matt. This is Paula. I have Kathy Cubitt's question here. Will the Medicaid Research Center's Assisted Living in lieu of Services Participant Satisfaction Survey break out data for participants who transition from nursing homes and those who have been diverted from nursing home placement? There may be differences between the two groups.
So I don't know the answer to that question, but that is certainly feedback that our team will give back to the MRC, that it will be important to sort of delineate between the two. But I don't know specifically if it is cut out that way. Given the small number of participants currently, it may be possible to discern that, but it depends on how the survey process is occurring. But our team will give that feedback to MRC.
Thanks, Juliet. This is Paula. I have another question from Joey Mentry. Can you provide any more information on how the department intends to use electronic data sharing to enable the exemption of family caregivers and direct care workers from the community engagement requirements?
So, Jerry, that is a very good question. Pennsylvania intended to have a very robust data process and direction to try as much as possible through a kind of like an ex parte kind of process to exempt family caregivers and direct care workers that we know of through our managed care organizations or through our own data, or if they're a paid caregiver. And Pam and Lloyd had spoken about that, and we had pulled together a great foundation for a plan to try and implement and take advantage of that. Unfortunately, CMS has put out this interim rule, which has potentially put a wrench in some of those best laid plans. And so I can't speak today about how kind of definitively we are going to be able to do that, because we're working through the over 300 pages of that additional information, some of which has fundamentally changed some of the prior direction we had thought we would get from CMS. So we're sort of back at the drawing table a little bit, trying to be able to determine how much of our best laid plans we can continue forward with.
Hi, Matt. This is Paula. Should I go ahead and continue?
Yeah, please do.
I have a question from Mia Haney. We have asked that the HR1 work group be made open to public listening, but never heard a response from DHS on that request. Can DHS please consider opening these discussions to public listening so that all interested parties may hear discussions and not get information through alternative sources?
So thank you for your question, Mia. I'm not sure if you've missed responses at any of the MAC meetings, but I think, both the other deputies and I have kind of been on the same page with sharing that the HR1 subcommittee is not going to be opened up. It's intentionally designed to be a manageable group. And I think that's been relayed at all of these subcommittee meetings. I don't know, that's the response I can give you today. Certainly that feedback has been provided to Catherine Stetler, who's leading it, and has been shared with the secretary, but the intention and the design of that program, again, is to leverage the Medicaid managed care, Medicaid advisory committees and how we function as the advisory committees. So that is where it stands today, and I'm not aware of any changes to that, so it is not going to be sort of a public open process at this time.
Hi, Matt. This is Paula. I have another question from Anthony House.
After that, I see Carol has her hand up.
Concerns, questions from individuals in recovery. Will participation in psych rehab count, or those who volunteer service on advisory committee? Will these activities count towards requirements?
So, Anthony, that is a really great question. With regards to participation in psychiatric rehabilitation services, that's, a little outside of my lane with regards to if they are receiving psychiatric rehabilitation services. It is likely they may have a diagnosis that might exempt them, but I'm not necessarily certain given the changes in the direction of CMS with regards to work eligible or work able. If you're talking about if someone is acting in psych rehab services as, say, such as they are volunteering or working as a certified peer specialist, I would have some reasonable confidence that that would count as a volunteer or community engagement hour. Public service on advisory committees such as this one, I would certainly argue is providing volunteering in a public service and is a community engagement activity. Certainly, when we get to all of those very specific details, we in Pennsylvania would work to be as expansive as possible. This is a service that each of the committee members are providing with volunteering their time and expertise. So I would say yes, an advisory committee like this one should count as ours. I would definitely make that argument.
It's already 11 o'clock. Can I ask, Carol, is your question in regard to HR1?
In regard that living, and I know
I just wanted to
so.
wait until the afternoon, the 12:15
Yes,
comment.
that's okay.
Okay, you'll be first at 12:15. If we can remember that later, so we can have our presentation with Jesse Pierce. Are you prepared, Jesse? Thank you, Carol. Mike, Jesse. Jesse.
So Paula, do you see Jesse Pierce online or my team, or can we move them over to be a panelist?
I see her. I don't know who it is. I see the microphone and I see them unmuted. Carol, can you mute your microphone? Thank you. Yeah, I see Jesse keeps unmuting, but I don't hear anything.
So Jesse, if you called in via telephone, you may also need to unmute your telephone in addition to the system. I think it's usually *6. That might help.
Let's try this.
There we go. We can hear you now.
Yay! Hooray! Wonderful. Thank you for your patience. Sorry about that. Thank you all for inviting us to present. I'm excited to talk through some of one of the key innovations that we at the Department of Aging are moving forward in support of the implementation of Aging Our Way PA, which is our 10-year multi-sector plan for aging. I've never been on this call before, but it's nice to see some familiar faces. I know that we have a couple of long-term care council folks in the audience or former members as well. So excited to give a little update here. I'll start by kind of describing my role just really quickly, and then we'll jump in. So I'm Jesse Pierce. I am the Executive Director of the PA Council on Aging. I support an independent advisory council of mostly older adults, although they're not all over the age of 60. The majority of them are, and they act as a voice for older Pennsylvanians across the state. However, I am an employee of the Department of Aging, so I report to the secretary, and one of my main roles here is to support the implementation team for Aging Our Way PA. So I am very excited to talk to you today about the resilient environments in aging and dementia in your communities, parentheses, ready communities, funding collaborative project. We can go to the next slide, please. And the next slide, if you don't mind. Thanks. Great. Okay. So the Ready Communities Funding Collaborative grew out of one of the tactics from Aging Our Way PA, which I think many of you are familiar with the plan, but the plan has 163 specific actionable policy tactics. Tactic number 46, for those following along at home, commits the Commonwealth to funding and supporting policy and projects that increase age-friendly, dementia-friendly, and ADA-compliant communities. This project also emerged from robust stakeholder feedback that we got following the implementation of the plan. That, of course, I think we all know and have been discussing on this call, one of the principal gaps in solving problems in state government and across all our communities lies in funding. So the Department of Aging set out to create an innovative model essentially to streamline the process of matching public funds with philanthropic funds at the community level. It's a new model. It's really never been tried in this way before. So Pennsylvania is very excited to be piloting this model. And our goal is to increase funding for community-driven projects that support older adults, people with dementia, caregivers, and family members and neighbors of all ages in communities across the Commonwealth. We are working with a contracted vendor called Grantmakers in Aging. They have been a tremendous support to us, and their role is to act as the fiscal agent for the project. And this, we hope, will eliminate a lot of the challenges that are often faced when we try to match public funds, when we try to invite our philanthropic organizations to match public funding. We are going to test our public philanthropic structure and the strength of our model using through a pilot grant cycle, which is actually already up and running. So the Department of Aging has contributed $325,000 in seed funding for the project. And then the application for the grant is currently open to nonprofits, local governments, and project coalitions to apply at funding levels of $10,000, $25,000, or $50,000. And then once the applications close, once the application period closes, the Department of Aging will select projects that we hope to fund. And then our vendor, Grantmakers in Aging, will work with, we actually have more than 35 participating funders. This number goes up pretty much every time I give this presentation. But our vendor will work with participating funders across the state to identify matching funding for the projects PDA will fund. In the future, if all goes well, we hope to use this funding collaborative model to support additional grant cycles in future years. We may be able to leverage it for tactic-specific requests for proposals to support specific tactics from Aging Our Way or other plans, and also present a replicable model for other states and other sectors. So we can go to the next slide, please. The pilot grant cycle, the 2026 Ready Communities pilot grant cycle, will focus on projects that align with at least one priority from the multi-sector plan for Aging Our Way PA. So I'm just going to briefly review the priorities and then highlight some potential examples of projects that might fit within those respective priorities. And I always want to emphasize with these project examples, these are in no way intended to be prescriptive. They are merely suggestions to help us imagine what could be possible within each of these. So unlocking access is our priority that kind of opens the door to the rest of the priorities. Unlocking access focuses on ensuring that all older adults are able to access services and opportunities regardless of their background. So one example of a project that could fit would be creating culturally tailored programming for Asian American immigrants with dementia and their caregivers, focusing on a specific population. Aging in Community is creating safe, accessible, affordable housing and neighborhoods that meet people's changing needs over time. So a potential project example could be establishing an intergenerational after-school art, music, or theater mentorship program. With Aging in Community, we really want to focus on both the built environment and the social environment. We know that social isolation is a huge risk for older adults. So we want to be, that's why the project example doesn't focus on housing specifically or infrastructure, but we want to make sure that we're capturing the community aspect as well. Gateways to Independence, this one's about transportation, all things mobility, any way that you get from point A to point B. And making sure that that is, again, safe, affordable, accessible, and independent. So a project example could be conducting a volunteer-based walk audit to assess and improve safety and accessibility of active transportation routes. Caregiver supports. We know that our caregivers work very hard. We know that they are often the unsung heroes of our support systems. Both paid and unpaid caregivers need our help, and we uplift them in the plan. We also want to uplift them here. So a potential project example could be establishing a memory cafe where people with dementia and their caregivers can relax in an accommodating environment. And then education and navigation ties the entire thing together, making sure that people can access information from sources that they trust and that the information is easily understandable. So a potential pilot example could be, or a project example rather, could be piloting a navigator position that supports individuals with complex needs. Perhaps this could be done in a project coalition between a number of organizations to support the navigator position. And again, these are just some examples. We can go to the next slide, please. So some key dates to be aware of if you are a potential applicant, or if there's a project ringing a bell in your mind that's like, oh, this would be perfect. The application will close on June 12th. So we're closing in on that date. There's a ton of information on the Grantmakers in Aging website that I'll share in the chat after I conclude my presentation to support applicants in the application process. But that deadline is midnight on June 12th. Following that, we'll start our selection process, our project selection process here at the Department of Aging. And then Grantmakers in Aging will conduct their philanthropic matching process. And sometime in December, we plan to announce the awards for the 2026 grant pilot. And then in 2027, the awards will be dispersed, and there will be a 1-year project period. So we want the projects that we fund to take around 1 year to implement. Go ahead to the next slide, please. Okay, so I want to talk a little bit about the process here. I won't get too into the weeds, but this just kind of provides an example of like, how would this actually work? So let's say that, so an applicant submits one proposal. So let's say someone gives us a proposal for, I think I have an example slide next. So I'll hold off on the example. But so applicants submit one proposal. The Department of Aging scores the proposals. Funders are not required to contribute, but they consider. And then there is the potential for co-investment, with the department contributing at least 50% of the funding. And then awardees will work directly with the contractor, with the vendor, with Grantmakers in Aging, to coordinate the disbursement of the public and philanthropic funds. So our goal here was to make it easy for everyone, applicants, beneficiaries, and philanthropic partners. And we can go to the next slide, please. So here's an example. Let's say an organization applies for $10,000. They submit their application. The Department of Aging says, we love it. So we decide we're going to commit 50% or $5,000. Our partner, Grantmakers in Aging, will share the application with mission-aligned foundations, and they come up with a match of $4,000. So collectively, the project can be funded at $9,000. GIA would then reach out to the organization and say, can you submit a revised budget to us? We were able to come up with $9,000 for your project. Can you submit a budget indicating that that'll be enough? And if we approve that, then the award will be dispersed. The reason that we want to highlight this example is that full funding is not guaranteed. It could be above or below, depending on the appetite for match from our philanthropic partners. But we are going to aim to fund we're going to try as hard as we can to make sure that we can meet the full ask for each application that we choose to fund. So we can go to the next slide. Okay, so that's the presentation. Does anybody have any questions for me?
Do any panelists have any questions? Paula, are there any questions from the audience?
Hi, Matt. This is Paula. I have no questions from the audience.
Hi. I'm sorry, Matt. I am sorry to interrupt. There was a pause before when you asked for committee member questions. We do have one in the room. Can Shell ask her question?
Yes.
Yes, hi, this is Shell here. In regards to the unlocking access, the programming, does that mean to assist patients on their race or cultural background?
It certainly could. It really can apply to any specific demographic or just improving access more generally. The goal is to support any population that's historically marginalized or is facing some kind of barrier to accessing an opportunity or accessing care or accessing what they need.
Okay, thank you. I think it's a great idea.
Thank you.
Any other questions?
None from committee members in the room.
Okay. Paula, any online?
Hi, Matt. It's Paula. No questions for this presentation.
Carol, is your question in general, or is it about this topic? I'm going to assume it's still, her hand's still up for another question. Thank you, Jesse. Great presentation.
If there's no further questions, I'm going to go back on mute. I will post the further information on the Grantmakers in Aging website in the chat for anybody who's curious, but thank you very much for the opportunity to present.
Great. Thank you so much. We do have some time. Do we want to go back to questions?
Go
Go ahead, Carol.
I was wondering if there's only for the provider enough for the participant, right? The aging away grant program is for the provider and not for the participant.
So Carol, I just want to confirm, you're talking about for assisted living for providers who are interested in enrolling, what the requirements are?
I was talking about what Jen was presenting on about the grant program is only for providers, right?
I think she's talking about the aging or way for the presentation. I think her question is
yes. Is that only the provider the right grant?
Oh, I see. No, it is not only for providers in CHC. The community grant that they were talking about in aging is open to community-based organizations. It's not just an enrolled provider in CHC. It's not a Medicaid program at all. It is for all folks in the community. And so, yeah, so I wouldn't just think of it as a Medicaid program because it's much, much bigger than that. It's for all aging organizations, community members, et cetera. and townships, boroughs, things. It's very expansive. So I would encourage you to go to the website to get the specific details, but thank you for bringing it up to give us the opportunity to clarify. It's not a community health choices grant.
Harold, did you want to ask your question that you had earlier?
Oh, yeah. And Julia, I know you're gonna read the document about the options, but I wonder if you know how much assistance is given in the assisted living program. Julia, or anybody, did you get what I said?
I'm going to need you to repeat it one more time, Carol.
I think part of it was how much assistance is provided in assisted living. Is that right, Carol?
Yeah.
Okay. So assisted living residences are regulated by the 2800, Chapter 2800 regulations. And so they are to build out a service plan with the individual. And they are able to address their activity of daily living needs, support with, sort of ancillary activities. Assisted living can help with some skilled needs as well, arrange for therapies to occur. So they work, they then, if someone's in assisted living as an in lieu of service, that assisted living residence works in partnership with the participant and the service coordinator to make sure that there is a plan that addresses the needs to meet their goals within that setting. So unlike personal care homes, they can provide more skilled care and services.
But Julia, if somebody goes in to assisted living and they find out that it isn't a good match, can they come back to long-term living with services?
So just like, if a participant chooses to go into assisted living and they determine it's not a good fit for them, they would work with their service coordinator to put forward a goal to transition to a different setting. So, if they, or if they went to assisted living and they've been there for a while and they've decided they want to become more independent and seek out their own apartment, they will be assisted in doing that as well. It is not a once and done deal for anyone. It follows the same kind of experience as anyone who's, selecting assisted living. It's a choice to be there and a choice to leave.
Okay, thank you.
Thank you for the questions. Thank you for the responses. With that, we will take a 10-minute break. See you all back here at 11:35.
Great. For folks in the room, just a reminder, when the green light is on, they can hear all of your conversations online. So I would hold and pause until that light turns.
We're going to get started in about 1 minute. So fill that beverage. Okay, I got 11:35. Paula, before we get started here, has anybody come in that we have not recognized?
Hi, Matt. It's Paula. Neil Brady had joined.
Okay.
That is the only addition I have.
Okay, thank you.
You're welcome.
With that, we are going to move into a presentation on the service coordinator's role in nursing facilities from the MCOs. So we have 3 representatives, 3 volunteers.
Hey, Matt, it's Randy Nolan. How are you?
I'm well, Randy. How are you?
Good. I'm going to preface this presentation and kind of oversee it and walk through it so we get what we need out of this. I have a group of service coordinators from each of the MCOs. There's a couple, they all work with nursing facilities. There's a couple supervisors, a couple managers, and a couple frontline SCs that will be able to answer some questions and walk through some presentations. Question-wise, once they come in, we'll filter the questions and work through them. The goal is to provide some education and background on what they do as nurse facility service coordinators and the work they do with the facilities and maybe any barriers they're having with the facilities. So we'll kind of walk through that part of the process with them. When we ask questions, I'll direct them back through the questions. I'll switch off MCO order every once in a while so that, you know, one of them's not first all the time and on the spot all the time. And it also gives the opportunity for the other staff not to just say ditto, ditto, ditto. So we'll make people talk through it. So with that being said, we'll go ahead and move on to the next slide. And then we'll bring them up to the table to go over some stuff. So. So basically, just to give you some background, the service coordinator's role in the nursing facilities, basically they're to help ensure participants have the opportunity to reside in least restrictive settings of their choice. They work with the facilities to develop service plans based on the person's individual needs and desires. They work on developing partnerships with the nursing facility's multidisciplinary teams to work towards the participants' goals. They partner with facility staff to assist participants and advocate to ensure high-quality care. They identify participants with a personal goal that want to transition back to the community. They work with specialists, behavioral health providers, to durable medical equipment providers to get the equipment and materials and services that a person needs. And they will assist with relocation of participants during emergency situations. We had a number of them in the last year. The service coordinators were on the ground and really assisted in helping move people out of those facilities, worked with the families, kept them coordinated, so they did a lot of work around that. Hopefully in the next year we don't have situations like that, but they're always on the ground and prepared to do that. So what I'll do is, there was a set of questions that came up that were kind of outlined, and so I'll bring the service coordinators up to the table and we'll have them sit around and discuss the questions that came up. Oh, you got mics and stuff back there for them?
Oh, no, they should come up. Honored guests.
See.
And presenters. Kathy's in on second class. They are foremost.
So give us a minute as we move them all up to the table here, and then we'll start going round robin and having discussions with them. Reminder to you folks, please, when you speak, identify yourself and what MCO you're with. Mics are fairly easy to use. You just push a button up on them and talk. There's seats up here, folks. Yeah, I bite, but I won't today. I'll try to be nice.
Come on, good one up. Are you almost here? Anyone brave will take the hot seat right here.
And then some of that,
Okay, Matt, we got the logistics set up in the room. They're all around the table. I'm ready to have a discussion. The first question on the next slide. How do the service coordinators do assessments, and what are the assessments used for? And I'll go in random order here and call them UPMC service coordinators first.
Hi, my name's Chanel. Can you hear me okay? Can you hear me okay?
It's a little faint.
Yeah, it's a little low.
Can you hear me now?
Much better.
Okay, perfect. Hi, my name's Janelle. So we complete a comprehensive assessment that's done initially and annually. It's also completed after a participant has a hospitalization and there's been a change in need. We also complete an outreach assessment that is done, 1 out of 3 of the outreaches done quarterly is done in person. These are just like a check-in visit to capture any changes in needs, to ensure all care is being met, any concerns with care, and also to check in and make sure that there's no desire to transition back to the community. And then we also complete a PASS-R assessment. This is done whenever someone is a PASS-R 2 and has been deemed eligible for services. It helps us identify activities that are important to the participant and then helps us indicate what specialized services they may be interested in, and also helps us collaborate with the nursing facilities and their support as well. Thank you. I'm going to put Randy on the spot because PASS-Rs are pretty long
acronyms.
Randy.
Explain what it
Randy knows a lot about the PASSAR process. It's the pre-admission screening resident requirement process. There's two pieces to it. The first piece is a screening to determine if a participant who's entering a nursing facility has a mental health diagnosis, an IDD diagnosis, or another related condition diagnosis. If they do meet the criteria and have one of those diagnoses, then they have to go through the level 2, which is a full evaluation assessment. That for nursing homes, it's usually completed by the AAA or field operations, which is part of OLTL. That assessment includes review of all medical notes, background, psychiatric evaluation, school records, and needs that the individual may have. The goal of the level 2 is to ensure that people go into the nursing facilities are being appropriately placed in a nursing facility and would not benefit from other services. The other goal is to determine whether they need what's called specialized services. Those are services that anybody in the community could get that have to also be offered to people in the nursing facilities. That can include day programs, counseling, different types of services. And there's a long list of them on the PASSAR form. So it's the process that every nursing facility has to go through. It's been part of the program since 1989. And yes, I was working in a nursing facility in 1989. I am old. I have worked with the PASSAR process over the years with the department. I've actually redesigned, rewritten the forms at least 5 or 6 times. So that it's a big component to ensure that people are being appropriately placed when they have a certain diagnosis or a certain need. All right, so we'll move over to PHW. Look, they're all sitting around the table going, you talk, you talk, you talk.
So for the SCs, when you're going to talk, turn the microphone on, and then after you're done talking, switch it off so that the folks online can hear you more clearly.
Okay, my name's Kimberly Shin. I'm with PA Health and Wellness. I wanted to speak a little bit about the preparation before we do an assessment. Most of us have access to EMR, electronic medical records, from the nursing facility. So we're able to go in and get the face sheet, the care plan, the MDS, which is done quarterly by the nursing facility. We look at medications. We can look at progress notes. And when I do an assessment, especially an annual assessment, I go back to the year before to the documents to see does a person need more or less help with their ADLs? Is there any more behaviors? Have the medications changed? So we are constantly tracking how their progress, how they're doing on their goals. We do goals every year. And that's about it. For the, I just wanted to say that there's a lot of preparation before we just go in and say, hi, how are you?
Hi, Arzelia. In addition with that preparation, we also have partnered with Real Time Medical to get that real-time data as well.
All right, AmeriHealth.
Hi, my name is Nicole Snyder, and I'm from AmeriHealth. Basically similar to what they're saying, we also do, but additionally, we also speak with the social worker and try to engage families, attend the care conferences as needed as well, just to get that multidisciplinary approach to getting that, like you said, the comprehensive assessment and getting a better picture of what the participants' needs are that they might not even be able to recognize, and also seeing like if there's cognitive deficits or additional services that we can assist with.
Hello, my name is Jamie Johnson. I'm a supervisor at AmeriHealth. I just wanted to add that with the assessment, we're using all the elements that were discussed. We are using them to support the participant and also identifying goals that are important to them, not just transitioning into the community, but just seeing what they need to feel safe and comfortable within the nursing facility. So those assessments are bringing those things out. And giving them knowledge during those assessments just to know what services they have access to, whether it's they qualify for specialized services or they need understanding of what nursing home transitions are, or just developing plans that are centered around them. So we use all the knowledge that comes from our assessments just to help build that person-centered approach for them so they know where they stand at where they were in the place that they are, and if they want to transition and move forward, how they can do that. Thank you.
All right, thank you. We'll move on to the next slide. Next question. Do service coordinators participate in the care planning conferences, and what is their role in that conference or meeting? And we'll start with PHW on that one.
My name is Teresa from PHW, and we do participate in care planning conferences when we're invited, and we do that as part of the integrated team. We want to make sure that we are advocating for the participants, their wants and needs, making sure they're getting the quality of care they need, if there are any gaps in their care. We're just basically trying to make sure that the participants getting what they want and need at their level, whether it's in the nursing home or if they want to transition. So we're working as a group.
Okay, AmeriHealth.
Again, Nicole from AmeriHealth. Yes, we do participate in the care planning conferences, basically to advocate for the participant and to support their voice in the nursing facility when they have concerns or have something to address. Again, same thing with the nursing home transition. Example, like I had one recently where the participant didn't feel like they were being heard. The family was kind of overriding their desire to go to the community due to concerns with her cognition. So we were able to advocate for her to have like a competency evaluation, which the family was then comfortable with her decision to transition because she was deemed competent at that point to make her own decisions and to make safe decisions. So it's just there to assist them in whatever their goals of care are, and being able to collaborate with the different services like therapy, nutrition. A lot of participants have complaints about their food at the facility, so we're there to kind of provide that voice as well. So just to be there to support them.
UPMC.
Hi, this is Sherry.
I'm Sherry with UPMC Community Health Choices. We also participate in the care plan meetings when we are asked. We also ensure we participate when we are invited and asked to attend. We also make sure that the participant themselves are invited, that the families are invited if that's what they prefer. And then we do our regular visits, and we just ensure that their needs are being met and their voices are being heard. But we always will be there if they request us to be there. Yes. And then we also hold our own meetings if needed. If we find that there's a need, the care plan meetings are held quarterly in the facility, so there might be a need in between that time. So we always encourage the participants, don't wait until the care plan meeting. If there's a need or something that we need to address, then we would request a meeting to be held as well.
All right, thank you. Okay, move on to the next slide. So the next question is, how do service coordinators determine whether residents' care needs are being met? And what do service coordinators do if a participant has complaints about the nursing facility or tells you that they are receiving poor quality of care? And we'll start with the Mayor of Health.
Hi, I'm Andrea from the Mara Health, and so when meeting with a participant, if they do express a complaint or a concern with the care they're receiving, we try to rectify that immediately if possible by meeting with nursing facility staff, the social worker, nursing staff, director of nursing, whether it also be the administrator, and then just following up and making sure those care needs are being met. If it's more of a severe complaint or depending on the severity of it, that may also require adult protective service or older adult protective service referral to be made on their behalf. And then we do follow up with our internal critical incident process as well.
UPMC?
Can you hear me? Hi, this is Erica Halverson from UPMC. We follow the same rule. We really want to make sure the participant's complaint, so to say, is validated so that they don't feel that what they're reporting is just swept under the rug. So we meet with the social worker, director of nursing, and if it's a very severe or anything that we need additional support with, we can outreach our critical incident team and APS as well.
PHW?
Hi, this is Teresa from PHW. We do a lot of the similar things. If a participant has a complaint, we want to make sure we're validating their feelings, how they're feeling, and whether or not they want us to take it a little further. Because sometimes they just want to be heard, and a big complaint is about the quality of the food. They don't like the food a lot. But that is not necessarily something I need to take to the social worker, so we try to validate their feelings. If it's something that is very concerning, I talk to the social worker. I'll go to the director of nursing or the nursing staff. Again, if it's severe, then we would follow our processes, critical incident ombudsmen, making sure they know who their ombudsman is and how to get a hold of them, and making sure that their needs are being taken care of.
Okay, thank you. We'll move on to the next slide. How do SCs determine which residents should be referred to nursing home transition? UPMC?
Hello, Erica Halverson again from UPMC. We work with the participant first, of course. If they have the desire to transition into the community, that's where we start. And then we work with their person-centered planning team, which would include the facility staff, the doctors, therapy activities, anybody that works with them regularly and that can help support their transition into the community. Even if it's not able to be done, maybe it's not a healthy or safe transition at that moment, we work as a team to put in place goals that will get them closer to transition.
W.
My name is Shamira Flagg. I'm one of the senior transition specialists over at Pennsylvania Health and Wellness. So with Pennsylvania Health and Wellness, we have a specialized nursing home transition team. What we do at Pennsylvania Health and Wellness is we first use real-time medical to see if a participant does want to transition. We do meet with our participants quarterly, and if they do desire that, we also meet with our social workers, also with our transition team as well. They come in, we do assessments with them to determine if they are a good candidate for transition. And then we also work with our team, their care team, attend those care conferences to eliminate any barriers to get them to be able to safely transition into the community.
I have heard this person and someone else also asked, or they were talking about real-time medical. I assume that's kind of some kind of software. How does that indicate somebody wants to transition?
Could you also
Yeah, Matt,
tell us what it is?
Yeah, that's a good question. I was going to ask them to explain that at the end, but I'll ask them to do it now. Do you guys want to talk about what your real-time medical system is?
Hello, this is Arzelia, PHW, one of the managers that oversees nursing homes. So Real-Time Medical is a cloud-based platform that allows us and gives us the data that is entered into the electronic medical record in real time. So as the nurses and therapists are entering in the data, we're able to see that data in real time. And so within that platform, there are levels that and grades that allow us to determine how a resident is able to transition, if they're able to transition. They're color-coded, green, yellow, and red, obviously, for those easy alerts to let you know that this person's ready to transition. We are able to see all of their clinical information, PT, OT, anything that's entered in the EMR record, we're able to see. If a person has a fall, if a person goes out to the hospital, we're able to see that, and it actually has become very helpful when we're trying to locate residents. If they've been discharged to other facilities, we're able to go in and see them and find them.
So this is Juliet. I'm going to hop in on here because I have Anna Keith's voice in the back of my head. For folks who remember Anna Keith, we have to share her now with multiple states. She's not just Pennsylvania anymore. This is one of her babies of innovation. And I just want to highlight in terms of innovation in CHC that, and you made this point, but I want to highlight it for folks, that they use real-time medical to proactively engage residents that they feel would be good candidates for NHP. So they're not just waiting for someone to kind of raise their hand. They're having those proactive conversations based on that green indicator that real-time medical kind of assesses for. And I think that's a really important thing to highlight because that's a different change that came about through CHC's implementation, that actively going out and identifying folks to encourage transition conversations. All right, Randy, back to you.
All right, AmeriHealth.
Hi, I'm Desiree with AmeriHealth. At AmeriHealth, whenever a participant expresses their need or want to go to the community or transition to the community, we make the referral through our internal nursing home transition department. We collaborate with the social workers, therapists, facility staff, just to talk a little bit more about what their needs are and what barriers there are. It's not only the participant, but I have had social workers that reach out and say, hey, this participant is interested in going home. They've finished their physical therapy. They're ready to move on. So we kind of start helping them with the referral process. If they haven't had waiver services, reaching out to independent broker, getting that referral made for them and starting that process for them.
Hi, this is Nicole. I'd like to add to that, when we're reviewing the medical record, the MDS also indicates plans for discharge. Their facility care plan also does, like you said, the social worker might notify a family. So it's basically anyone that's able to speak on their behalf as well, and then we confirm it with the participant that that's their desire, and then we move forward from there.
Thank you. That is a key point. On the MDS, which is the minimum data set, that's the assessment that every nursing facility has to do on every resident, on admission, on trigger events, on quarterly basis. there is a question that asks them if they want to return to community living, and that's where some of the information comes from as far as the MCOs finding out of people's desire to return to the community. So it is part of the assessment process the nursing facility does. All right, so on to the next slide. What is the service coordinator's role in the discharge process from nursing homes? We'll start with PHW.
Shamira Flag again from PHW. So with our discharge planning process from nursing homes, it starts when we first get the referral for nursing home transition. So with our team, as soon as a participant expressed they want to leave the nursing facility, we're meeting with the participants to see what their barriers are. We're coordinating with the participants, their supports, their social workers, their therapists, their physicians to see what services they would need in place to get home. And then with our teams, we're actually going into the community to see what that home residence looks like, to eliminate any barriers. So whether that barrier is they need any type of home adaptation, any type of deep cleaning processes, we also establish any services that they need in the community before they get home. So we're doing great things with our assistive technology program right now. Community integration is also a big thing that we're doing, and establishing any like services like they need for, transportation or we also do assisted living right now too. That is really big within our part of the state right now, and just anything that we can do to safely set them up for success once they get discharged.
AmeriHealth.
Hi, this is Andrea from AmeriHealth. So just to add, to go along with what you said as well, we do participate in, if someone applied for home and community-based services, we complete the comprehensive needs assessment with them in the facility and then we collaborate with our utilization management team to determine medically necessary services. We do participate in the discharge planning meeting with the nursing facility. So that might include, obviously, the participant, anybody they would like to be a part of that meeting. If there's a nursing home transition provider, coordinator involved, also engaging with our community service coordinator that will be taking over the case in the community. And during that meeting, we address any durable medical equipment needs, any home health referrals that may be required, and then just ensuring also that they have a primary care physician set up in the community for discharge, because having that visit within a few weeks of discharge is important to ensure they get their medications, and also having a pharmacy set up. And then we also, on day of discharge, meet with the participant at the facility just to ensure that they're getting their discharge orders, they're being educated on their medications for home, and making sure any durable medical equipment is in place for their discharge, and then also home health referrals.
Pam, is your question for now, or can I wait until the end?
No, I'm sorry. I it can wait to the end. Sorry.
Go ahead, Randy.
So I'm going to hop in because I'm surprised Lloyd hasn't, just to confirm that if they had behavioral health needs as part of the transition, that appointment is also being set up and planned for.
Yes, Jamie Johnson. I will just add that we make sure that if they are leaving with services after we've done our comprehensive need assessment, that those providers are all set to go the day of discharge, so they're not left with a gap of service. So we kind of just do the full circle just to make sure that the transition is smooth and that everything is in place, along with like the medical appointments and referrals to appropriate services that might not necessarily be in the home, but like you said, community-based behavioral health services as well.
Matt, this is Pam. Can I actually ask a question, because it has to do with what they're talking about right now? The responses that we're getting are about how the role in cases where nursing home transition is involved. But what is the role of the service coordinator in discharges where it's not a nursing home transition case? It's just people who are being discharged for one reason or another from the facility. What's the role of the service coordinator in those non-nursing home transition discharges processes?
This is Jamie Johnson with AmeriHealth. Every participant that is enrolled in our MCO and is discharging into the community, if we are aware of it, we are considering it a nursing home transition, whether they are going with home and community-based labor services on, whether they are determined to be NFI eligible. So we still work to provide a safe transition. Unfortunately, if they're not eligible for home and community-based services, that means we're not able to put those authorizations in, but we have other resources such as we'll set up, as long as they're in agreement with it, a 6-week home delivered nutrition plan where they'll get food delivered to them and also have access to nutritional counseling. And we ensure that we give them resources for the community that they can access, and it necessarily is not tied to waiver benefits. So every individual that is transitioning from a nursing facility under our plans, we are still identifying them as NHTs and working with them for a safe transition.
So to kind of clarify, operationally, it doesn't look different. It just doesn't necessarily wind up as a data point on our reports as a traditional transition, but operationally, they get the same service assessment and supports and sort of identification process.
Quick follow-up. Hi, this is Pam again. How do you find out that those people are being discharged? How does that happen?
Jamie Johnson from AmeriHealth. The nursing facility team will inform us, and sometimes the participant will. So there is an opportunity for the service coordination team to be informed, and we will do the necessary steps to determine eligibility and support with transition. So it does, referrals per se with a hand raised or a nursing facility social worker, nurse, director of nursing bringing it to the service coordinator's attention that someone wants to transition into the community.
All right, thank you. And I'm going to turn it over to UPMC to answer the question and, the follow-up questions that came through.
Hi, it's Janelle with UPMC. So the service coordinator's role in the discharge process is to address and identify barriers to the participant discharging back to the community. Barriers can range. Even a barrier could be ingress and egress, a participant getting in and out of their home perhaps. Another big barrier that I've dealt with within the past couple years has been diagnoses such as diabetes, making sure the participant is educated on their diabetes, making sure that there is documentation in EMR of nursing doing diabetic training. Also, like blood thinner medication, depending upon what blood thinner medication they're on, they could be doing testing weekly, making sure there's transportation to and from to ensure that they're getting that testing done, making sure there's PCP appointments set up. We also have 2 discharge meetings to ensure that everybody is collaborating, participant, their supports, nursing facility staff, to ensure that everybody knows their role in the discharge process to ensure the participant's health and safety is ensured after discharge.
Hi, this is Renee with UPMC also. I just wanted to add, to answer one of the last questions that we got from a committee member. We do strive very hard to work with the nursing facility staff to make sure that they tell us about discharges ahead of time. We all know we have these fantastic services that we can put in place, but we need to know that they're going so that we can take those steps. We've worked with our network department to strive to make sure that they understand how important it is that they tell us about discharges. Unfortunately, I think everybody here at the table can testify to the fact that they still happen. They still discharge people without telling us. One of the things that we have done, we have a team of nurses at UPMC that help us with discharge planning. We created a post-discharge assessment that as soon as we find out a person is discharged from a facility, that assessment is completed and it is set up to identify any concerns that could result in a safety issue for a participant. Things like, do they have their medications? Do they have food? And as they're doing this assessment, it's not like we're just doing the assessment and identifying the issues. We are resolving them real time at that exact moment so that we can make sure that we ensure our participants' health and safety in the community.
Thank you for that. What is your name?
Renee.
Renee, thanks.
You're welcome.
All right, and since Pam, you asked a couple questions, I'm going to give PHW a chance to add any additional information based on your questions.
So, Shamira Flag again from PHW. So, I can agree with everyone at this table. We do hear struggle at PHW with our facilities as well, with participants discharging and facilities not telling us. When we are notified either by the participant or the facility, we do also work in real time to find where our participants are going and discharging. So we, like I said, at PHW, we do have a specialized team that will actually in real time go to either that community address to resolve any barriers, and we do work in real time to make sure that they do have a follow-up appointment with their PCP. They do have any medications. We do work with our providers to make sure that they do have food on the table. We do have SILs that we work with in the community that we pull together to work with getting any resources, because sometimes when they do leave the facility, they just leave the facility with the clothes on their back. So we work with them because we establish those relationships with most of our participants in those facilities because we are in there daily. So we want to make sure that, for one, they are safe and that we are able to find them. And then again, like I said, we do have real-time medical, so we can rely on that to see if they have been hospitalized within like the last 24 hours or if they have discharged.
All right, thank you. All right, the last question before we open it up to questions. What obstacles do service coordinators face while performing their duties? AmeriHealth?
Hi, this is Andrea from AmeriHealth. So one obstacle that I have run into a few times in the discharge planning process is you're collaborating with, you set a discharge date, you're collaborating with a bunch of providers with the goal of that discharge date in mind. However, sometimes personal care agency provider last minute isn't able to staff that case, or we wait on the waiver code to be in place for discharge, so those providers have authorization to start those services. However, there are instances where that code is not in place for that date of discharge, so we may have to have some flexibility with that date and changing that date a little bit. But I'm always pretty much upfront and honest from the start of the process with my participants that could happen, and I appreciate their flexibility with that as well.
MC?
Hi, this is Susan with UPMC. One of the biggest challenges we have, too, is getting access to the facility electronic medical record. So the facilities give us permission and access to these systems, and sometimes it can be a challenge for the facility to give us access to those systems where we're able to see physician orders and all the treatments that they have, look at the medication record. So that's a big obstacle that sometimes we have working with facilities.
All right, PHW.
Okay, I think one of the barriers I'm sorry, my name is Kim. I'm with PA Health and Wellness. One of the barriers is also one of the best things about being a service coordinator, and that is making connections with the people in the facility, with the social workers, and with the director of nursing, therapists. But sometimes the barrier is a high turnover of social workers in the nursing facility. The barrier can be a high turnover with supports coordinators as well. Once we have somebody new, you have to get access to electronic medical records. The easiest one that we use is point-click care. It's very easy, user-friendly, and if we have that and we have real-time, I have 6 facilities. All 6 of mine are point-click care, and 5 out of the 6 are real-time. So I don't have to bother the social worker that much, so that other facilities don't give us access, or it's very difficult to get access. They want you to use their own computers. There's just a lot of conflict there sometimes. So the big thing is to get a good relationship, to build relationships with everyone in the facility, and then that makes our life much easier.
All right, thank you. That's the questions that come in. I think the next slide is the little faceless question guy. We need to figure out how to change that. So I guess the next thing, Matt, is to look at any questions from the committee.
Right. Do we have, Pam, do you have a question?
I do. There's a scenario that we see kind of on a regular basis, and I'm wondering how it should be handled. A person will, have an accident or something like that. They're in the hospital, they go into a nursing facility for rehab. They're not ready to leave after rehab, and they stay for months or a year or maybe a couple years. And then eventually they're recovered enough that they no longer need nursing home level of care. And the scenario we see is that what happens then is that the nursing home tries to discharge them. And in the meantime, the person either maybe didn't have housing to start with or has lost their housing. And now they want to discharge them to, for instance, a homeless shelter. What should happen in this scenario? I guess what should happen in order to prevent this from happening? And what's the role of the MCO and the service coordinator if we're facing something like this with a person who's being discharged now, maybe is even probably NFI at this point, but has nowhere to go?
Okay, thanks, Pam. AmeriHealth.
Hi, this is Nicole from AmeriHealth. I actually recently had a similar scenario where the facility was looking to issue a 30-day discharge notice for someone and send them to a homeless shelter. And that's where our care conferencing has come in, where we're advocating and letting them know what we are doing. This particular individual was already active with a nursing home transition coordinator and looking for housing, have been on waiting lists. So we just keep an active, open communication with the facility about where we're at, and they've been patient, and just knowing that that's actually a better option for them too for a safer discharge is if they allow us to put those services in place.
PHW.
This is Shamira from PHW. At times, I feel like it comes down to education with our facilities and with the social workers. I try to educate all of my facilities, and our team does too, that our nursing home transition program with these participants help those in need of housing to find affordable housing in the communities, because a lot of times with participants like that come into the nursing facility, they lose everything, including identifications. They have trouble with their finances to even establish housing in the community, and our team actively helps with that. We have community partners that will help establish getting their, identification back and help with enrollment with applications to affordable housing. And sometimes we just have to kind of educate our social workers and facilities that they are working with our nursing home transition team. They're actively on wait lists, and it's better for them to work with us to get housing in place for them to safely discharge into the community instead of a shelter.
UPMC.
Hi, this is Renee. I agree, education of the nursing facility staff is very important, but I think even more important than that is education of the participants themselves. They need to understand their rights to be in that facility and that the facility can't just discharge them to a homeless shelter. We've done education. Whenever we find out about an eviction notice, we immediately go into action. We make sure that the participant understands that they have the right to appeal that. If they appeal that, they might lose, right? But it still gets us more time to be able to get them housing or whatever it is that they might need so that they can be safe in the community. So we do continue to educate the nursing facility staff, and I have mentioned in several meetings myself to the nursing facility staff, do you realize if you discharge this person, it is an unsafe discharge and an APS referral, and they are going to come back and investigate. And pretty frequently, that actually gets them to change their minds.
I can reiterate, yes, Adult Protective Services would go out, investigate, and try and figure out who made that decision and follow up accordingly.
Let me ask a follow-up to this whole line of question. What involvement or work have you done with the ombudsmen in your area? UPMC?
We do. We also involve the ombudsmen immediately, and we make sure that the participants know about the ombudsman, and we provide contacts for them so that they can reach out to them as well. They're often also very instrumental in helping us to delay these discharges or stop these evictions so that we can make sure that we can get services in place so that they can be safe in the community.
Can I ask one more follow-up question? This is Pam. If we, for instance, have a case like this, who do we reach out to at the NCO if the service coordinator is not clear what they need to do to try to get someone to intervene?
So a service coordinator is not doing what they're supposed to do?
Well, they haven't so far. So, I mean, we could try reaching out to them, but I'm just taking advantage of the fact that I have you all here because sometimes the service coordinators don't know what to do.
Sure, absolutely. We have a hub number that you can call into, and you just need to let the person know that you have some concerns about a particular service coordinator. That message will be sent immediately to their supervisor or manager. We will do an outbound call then. If we're not available to take the call at the moment, we will get back to you within 2 days, and we'll get some specifics on what the issue is, and then work internally to make sure that we resolve it.
Thank you.
Any other?
Hey, I want to
go ahead.
Yeah, Matt, this is Randy. I want to let the other two MCOs answer the question about their work with the ombudsman. So, Mayor Health.
Go ahead.
This is Nicole from AmeriHealth. Similarly, we do contact the ombudsman whenever there is any circumstances that they might be being discharged. We've assisted in contacting the ombudsman or providing information depending on what the participant wants. We've also assisted in the appeal process and being available on the calls as needed to provide any additional insight and information regarding what our role is and what services we're providing to aid in that safer discharge.
PHW.
Hi, Arzelia from PA Health and Wellness. Ditto for what everyone has said. We have also decided to pull in the ombudsman just because some of our SCs were not as familiar with their role, and so we brought an ombudsman in to provide additional training to our SCs so that they would be able to then in turn have our participants be aware of the role of the ombudsman as well.
Any other questions from the committee? Lloyd, I figured if you weren't going to ask, I was going to ask for you.
I'm going to grab that mic. For the service coordinators, my role is primarily behavioral health advocate. Had family members with behavioral health issues, and I've worked in the field for a number of years. And I wonder about your impressions and feelings about the training you receive in behavioral health issues, first of all, in assessing them, but also then in finding ways and places to which you can make referrals for prompt and effective action when you do find a behavioral health issue in one of your residents.
Okay, PHW.
Arzelia, Manager, PA Health and Wellness. So within the assessment, the service coordinators, if they've determined that there's a behavioral health need, a couple of things. They do complete a referral to our behavioral health department. They will pull in our complex care team if needed to, have an ICT meeting to discuss what behavioral decisions need to be made is with regard to that participant. And then there is, as far as training, we have training that we complete yearly to be able to review and determine the different behavioral health aspects of a participant.
UPMC?
We also have questions in our assessments that can give us some insight into behavioral issues or concerns that there might be for a participant. We have a very robust educational program at UPMC. All of our staff are trained on hire with regards to behavioral health, and then they also have annual training on how to identify behavioral health issues and on those services that are available to our participants in the nursing facility so that we can make sure that those are met. We also have an additional step that we take. We have a monthly meeting called a consult with a psychiatrist where we have some really very complex behavioral issues and we just really don't know where to go with it, and the facility doesn't know where to go with it. We can present those cases to psychologists and they're able to give us some additional insight and resources.
Mayor Health?
Amy Johnson with the Mayor Health. As all the other MCOs, we also have mandatory behavioral health training that we provide to every service coordinator so that they have awareness annually of how to assess. With our assessments, there are questions to determine behavioral health needs, and if there is one identified, we work with the participant to connect them to behavioral health services. We understand a lot of the nursing facilities do offer behavioral health services internally, but we do try to clarify with the participant if they feel those needs are being met. And if it isn't, we will work with our behavioral health department to connect them to additional services or explore other options that they can access. Also with behavioral health needs, sometimes it is tied to the PASSR, so we do ensure that we review the PASSR level 2s to see what they are triggering for and work with the participant to let them know what their options are as far as what they can access under that mental health service, and utilize that and the MA408 form just to help them see in the sense of what each service is and the definition of them and how they feel if there's something that they would like to utilize. And if it is, we do try to make a goal with the participant in their person-centered plan to support them in connecting to those services, and we'll make the necessary behavioral health referral to access the service and connection and monitor as needed.
So Matt, I just wanted to do a quick time check. I know we started a few minutes late. We are 15 minutes into the public comment period. I know this is a great presentation and discussion. I do want to reserve a couple minutes to say a few words at the end, but I didn't know if you just wanted to direct folks that if they are here waiting to do public comment, that they could do so in chat, email, et cetera, and or to see how much longer you want to extend this topic.
Everyone that's listening, you can do all of those things that Juliet just said. But let's, are there any more questions for this presentation?
Yeah, I think Lloyd has a follow-up, and then I think we have one more for the audience.
Yeah, just one brief follow-up. When you do find the presence of a behavioral health issue and you make referral for services, whether it's in the community or in the SNF, do they get it? Are you able to get those services delivered?
They're waiting for you, Randy.
I know, PHW.
Arzelia, PHW. So, yes, depending on if it's, specialized services or just, services for behavioral health within the nursing facility, we want to make sure that we're, contacting and reaching out with our social worker, the psychiatrist or psychologist at the nursing facility. Sometimes they're already receiving those services, but they may not be at the level of care that is required. So we want to make sure that we're completing assessments and making sure that the services are appropriate. With regards to specialized services, we make sure that we, once we outsource the referral and we get confirmation that services are in place or have begun, we want to make sure we follow up to ensure that the actual services are in place within the nursing facility and also follow up within the community.
AmeriHealth.
Just to speak on the availability of services that you're discussing, my nursing facilities are in a more rural area. So unfortunately, a lot of the providers may have been exhausted already by the time someone does need something recently. Same thing, I had somebody who literally, there's only like 3 providers in that area, and he has not done well with those, and so they're not accepting him back. So the facility's trying their best to manage his care, but it's very difficult. So we're just continuously trying to outreach to different providers, but again, the actual proximity of the facility is very, very rural, so it is difficult. And that's unfortunately, we're just continuously exploring and trying to find something, but it does occur that that's possibly not happening because of the rural nature of the facility.
And just to also add to that, sometimes just getting transportation to those outpatient services is a barrier, so just making sure that they have those resources and that's set up for them to be able to go out to those services.
If I could just interject, Juliet was trying to imply very delicately, so I'll just say it very abruptly, that we need to keep our answers short so we can move on.
I didn't quite catch that, Matt.
We need to keep our responses shorter so we can move on.
Oh, no, but I'm just going to hop in because I just want to say thank you for highlighting the rural needs. Very real and very much something across the nation we need to look at and support. So thank you.
All right, I think, I'm going to hop in and I'm going to thank everybody from the 3 MCOs, all of you folks who've come in and done this. Huh? UPMC, do you want to answer the behavioral health question? You interrupted in the middle of it.
Sorry. In the interest of keeping this short, we do agree. Rural areas can be difficult, but we do work tirelessly to identify providers and get them in place, and then make sure once they are in place that they are what's meeting our participants' needs.
Okay. Now I'll thank all of you for coming in. And Matt, I think we're ready to go to the public comment period.
I understand there was one question in the room, and then Paula, we can go to online after that.
Yes, so I just want to thank the SCs. The public comments are separate from the SC presentation, so if folks want to get comfortable back in your other seats, thank you so much for coming in today and sharing your thoughts. And then we'll go to the public comment period, and I'll take my usual spot.
Actually, my comments were related to the presentation. In preparation for today's meeting and knowing that presentation was going to be on the agenda. I have a couple of things that I would like to mention.
Shauna, can you just introduce yourself?
I'm sorry. My name is Shauna Aiken, and I'm the CEO of Voices for Independence. We are seeing a trend where MCOs are not sending referrals for transition for people who use power chairs, people who use Hoyer lifts, or people who the service coordinator may be citing there's a need for too much care, not allowing certain participants to break down barriers to give them a chance to transition. And we are getting this from participants themselves. People are calling our office. People are stopping our NHT coordinators in hallways and facilities because they've expressed interest to transition and they're not getting an opportunity to do so. And we are also seeing folks who have diabetes be refused the opportunity to transition, citing diabetes management as the reason. So I just wanted to, we're beginning to see the type of transition be people who are ambulatory and only people who can transfer themselves out of their wheelchair. And so this is concerning to us. And I don't know who this goes to, but it's something that we've noticed and it's gradually increasing. And so I thought I'd bring it here today.
Yeah.
Thank you.
Shauna, thank you so much for your comments. Public comments for any reason at any time, not just on a particular topic. You've heard me say this multiple times, and I'll say it again today. If anyone anywhere comes across a participant who wants to transition from a nursing home and is not getting what they need, I would hope that as a Center for Independent Living, you would notify Randy and his team immediately to that need so he can jump on it, because we are HCBS oriented as a priority. You've heard me say it time and time again. And so if these are trends that you're seeing, these are also trends that I would hope my staff would be seeing because of those direct and immediate communications from you and your team about those situations. Certainly also the participant in the Ombudsman office would want to keep track of that, because that to me is a serious complaint that should be pursued, that we would want to support. I'm going to hand it over to Randy, but I take those very seriously. We're not looking at low-hanging fruit. I am excited about real-time medical because it has a proactive measure so folks can engage in conversations proactively. We're looking to try and support anyone who doesn't want to be institutionalized to find a safe plan home. Randy?
Yeah, I agree. I mean, the goal is to safely discharge people back to the community. So anytime you run into a situation like that, let us know. The monitoring team will look at it. Our participant support team will look at it. We'll work with the MCOs to figure out what's going on with the case.
I will get you names and participant numbers.
Okay.
Yeah.
Yep, sounds good.
Don't wait for a meeting. Get them right over.
Yeah, send them to me when the cases come up.
Juliet, in my defense for that, I honestly, the day before I come to Harrisburg, I say, is there anything I need to bring up? And this came to me as I was traveling yesterday as an issue. So I will get you those participants' names and any identifying information I can gather.
Fantastic. Thank you.
Sounds good.
That is very concerning. I mean, there's nothing that the department can. I mean, I don't know how you would look at data that would show that. But if that's really happening, I mean, isn't that a red flag of something even bigger?
It is a red flag, Matt, which is why you folks hear us say time and time again, please empower participants to use the participant hotline to make a complaint. No complaint is a bad complaint.
But there are a lot
Every
of people.
complaint is a good complaint. This is why you hear us time and time again when we have providers tell us they have trends. Well, if they have a trend and we don't have a trend, then there's someone not giving us data about a complaint or an issue in the system. And if OLTL doesn't have the data, then we don't have the trend, and there's nothing we can do to act on it. If we have general anecdotal information, this is a trend I'm seeing, it needs to be fixed, and we don't have people who are bringing forward the names, the date of birth, the time of incident. Did it happen yesterday, 6 months ago, last year? My team cannot fix it. We don't even know how to find the root of that issue, or if that is an issue, or if that is someone's issue that has happened that they have told 5 people. These are very important things, so I implore everyone, if there are complaints, to send them without fear of retaliation. Randy's not going to yell at a participant. MCOs maybe, not the participant, okay? Thank you.
Juliet, the participants are not all grown up, Juliet. That's my only point. Some of them don't have a strong voice or help.
George Gilmer here. Am I
I hear
unmuted?
you, but I hear you, Matt. But again, if there's a provider who's heard those voices and are not advocating on behalf of the participants in real time, I'm just going to say I get frustrated because they do know the participant and they can ask the participant if they can help advocate with them and then jump on it. It really frustrates me when I hear this and then we see a case that comes in and it's weeks ago that this conversation happened. I'm not going to lie. We want to be here to help, but we need everyone to help us do that. So I'm gonna stop there. Sorry.
All right, Matt, we have another person in the room.
I believe George is unmuted.
Am I off of mute now? Hello?
Yes, go ahead.
Yeah, go ahead.
George Gilmer. I'll echo. I have the same problem. I lost my 10 due to injury 6 weeks ago. No attendant care. Problems with lifting devices. Oh, and by the way, my food's being delivered down in my yard last time. So safe food on the table. All those things are questionable. So I'm running the same thing that with our chair. It seems like the low-hanging fruit is what wants to be delivered for attendant care services. So yes, it's very concerning. I'm experiencing it myself.
Thanks, George. Well, I appreciate you bringing that up.
Okay, Matt, we have somebody in the room. Go ahead.
Shay Robinson with Daily Death Care. I would like to thank the SCs for being here today. I am a PAS agency, and I'm just going to steal this time to ask the question. My question is that we know it's the summertime, and our SC. So my question is, are SCs allowed to add additional addresses to participants' care plan? We are getting pushback, and some clients are saying the restrictions make them feel like they are in jail. And it's home and community-based services, and I'm not saying that we need to add Walmart. I'm saying that I have a participant, for example, today, she received 70 hours a week. She's a wanderer, so her great niece takes care of her, and there are times where the niece will take her to her home. She doesn't feel comfortable if no one's at home to take care of her. She will take her to her home. So in the morning time, she's going to clock in at her home, at the niece's home. So we asked the service coordinators if she can add it in the care plan as an additional address, because we're also getting take-backs because these addresses where caregivers are clocking in and out are not in the care plan. But then we're getting pushback because the SCs, I feel like, I don't know if they're being educated on what they can put in the care plan, but it's really getting frustrated because it is the summertime. Participants should be allowed in the community. It's called home and community-based services. So I would like to get some more insight on whether or not an SC is allowed to put an additional address in the care plan.
Yeah, thank you for bringing this up.
And I do have names.
Send the names. So I appreciate you bringing that up because this has come up quite a bit with EVV. There's no restrictions on the service location from a policy perspective for electronic visit verification, or limits in terms of locations that participants should be able to receive those services in their home and their community along the guidelines that are required in the program, okay? No restrictions, right, for eligible locations, for example, except, if they're admitted to a hospital and you can't have double billing, that's not acceptable, right? These locations should be as part of the person-centered service plan. They should be able to be entered. I know all 3 MCOs do things a little differently, and that is allowed to address the issue, not restrict it, right? That's very different things. So if there is pushback and restrictions about things not being in a service plan, in a hypothetical, I don't know the details. The details always matter, and I don't know them.
I just want a blanket policy.
But OLTL's policy is that there are no restrictions to the number of service locations. They do and should be documented and reasonable to why those services are happening in that place. So if someone's supposed to be bathed, we shouldn't see the bathing happening in a supermarket, right? There's got to be some logic to that. But in the hypothetical that you put forward, I don't see any reason. I would imagine it should be incorporated in an emergency backup and safety plan, but that appears to be the safety plan the family is putting in place, hypothetically. Andy?
Yeah, and we'll follow up, and when I say we, Mike and his team will follow up with the MCOs on what their policies are as far as adding addresses to it.
That will be great.
We'll get back to you then.
That will be great, because then we'll have a printout that we can just send to the SC, because there's always like a lapse in communication. So that would be great if we can get that as reference.
Yeah, and so, all 3 MCOs are sitting here or on the line, so they certainly heard the message.
Yeah.
Again, they heard the message again.
And
we've talked about this multiple times.
Okay, Matt, I have no other questions in the room. I don't know if, Paula, you have anything?
Hi, this is Paula. I have several questions, so you'll just have to stop me when it's time.
Go ahead.
The first question is from Kathy Cubitt. What challenges do you, as service coordinators, face when a nursing home changes ownership? What are some of the issues participants raise after a new owner takes over? And how do you address these issues, especially when the problems appear to be impacting multiple participants?
So, Paula, the SC panel is concluded for that question, Kathy, but we'll send it out to the CHC MCOs and ask them to provide the SC's perspective on that. It's a very good question. I'm sorry we didn't get to it while the panel was here.
Hi, this is Paula. The next question I have is from Narander Kaur, and I'm sorry if I mispronounced your name. What provisions of HR 1 will actually affect people with disabilities in Pennsylvania, and how?
Yeah, that's a very good question. It is a learning in process with regards to HR 1 and what specific things will impact people with disabilities across the board. So, it's not, I would have a very long and complicated answer for you today, and a lot of moving parts that are still rolling out. What I would say right now, again, is that there is additional clarification coming out from CMS that we're working through. When we say people with a disability, that can run the gamut. So, I think the important thing is that it will impact all of us, people with disabilities and without disabilities, and one of the biggest impact areas is going to be uncompensated care. Our hospital systems, our health systems, when individuals who would otherwise be eligible are then not receiving services, be it from an administrative burden, be it from, limiting services across the whole system, What's going to impact everyone is uncompensated care in our healthcare system, potentially experiencing longer wait times in emergency rooms, experiencing more strain on hospitals in our rural areas. Those are real concerns that we certainly have. With regards to specifics, the Office of Long-Term Living, we are not making any specific kind of changes or cuts to our CHC program today. We're certainly working as much as we can as an entire department to be as effective and efficient with every dollar that we have and be smart about getting upstream and doing a lot of preventative care stuff. We have made some changes in our Medicaid program that you have heard about last year, which is we had to make a change in our GLP-1 medications and authorizations. So that's a big example. We are hoping that the bulk of the impact won't be necessarily seen until 28, 29 maybe even, so we have some additional time to plan, fully comprehend what's coming out from the federal level, and see how that will impact things that we do. Plus, we also need to know more locally what will happen with the budgeting process and things of that nature. So we don't have all the pieces to answer that question specifically. But keep raising it, and we'll keep doing our best to answer it. Thank you.
Hi, this is Paula. Next question is from Samantha Sakirka. Could you explain the 80-hour work requirement for Medicaid services again, and if there are any individuals who are exempt from this, such as individuals who are living with disabilities?
So the community engagement or the work requirements that have come out is really focusing predominantly on the Medicaid expansion population. And Pennsylvania is a state that has a Medicaid expansion population. We sort of expanded our eligibility allowances as a state. Individuals could be exempt from those work and community engagement requirements if they fall under the definition of being medically frail, as one example, or an individual who's providing care for someone who has a disability or meets the definition of a significant disability. The definition of medically frail is kind of been a moving target. And so that's part of what we're evaluating with the new interim rule that's come out for public comment. And that's something that I think is really important for this particular group, to take a look at that, and provide your comments on what you think that should be. How should they define it? What should those exceptions be? That impacts people with disabilities. And their caregivers and their families. So that's not, it's kind of defined more globally in the House resolution, but sort of how it's enacted in the finer details is in that CMS interim rule notification for public comment. But essentially, the other part of that explanation is that within a given month, briefly, an individual would have to show or prove that they have engaged for at least 80 hours in either work or volunteerism or formal education pursuits. So that's the other piece of it.
Hi, this is Paula. The next question I have is from Paula Hunt. Are the meeting notes or transcripts from the HR1 meeting available to the public?
Yes, Paula, the meeting materials, the PowerPoint publications were sent out on our listservs. So we encourage folks to sign up for the Department of Human Services listserv to get those notes and those publications. In addition, you can find more information by going to the DHS website, dhs.pa.gov. There is a website kind of dedicated to the House Resolution 1 and information and details. In addition, for folks who Substack, I'm not a Substacker, but I'm trying to be a Substacker today. There is a Substack with a DHS channel that also oftentimes includes updates and information on HR1. So multiple ways to engage and get materials. All right, we have 3 minutes, Matt. So back to you.
What?
We have 3 minutes left, Matt. So I'm handing it back to you.
Thank you. I don't see any more questions. Are there any questions online left, Paula?
Hi, Matt. It's Paula. No questions, but several comments. So I'll follow your lead.
Can you read a couple of them and then we can save some?
Sure. Okay. This is Paula. This comment is from Rebecca May Cole. I understand the desire to keep the HR1 committee manageable in size when it comes to who can contribute during the meeting. I respectfully do not understand why allowing interested parties to join in listen-only mode is not being considered. In terms of transparency, allowing the public to listen to the discussion would ensure all have access to the information shared. I believe keeping the size manageable for direct discussion. I don't believe the desire to just listen to the discussions. Understanding that public tax dollars are being used to fund services. I lost my place, I'm sorry. Understanding that public tax dollars are being used to fund services impacted by HR1, I ask that a listen-only option be considered again.
I appreciate those comments, Rebecca, and we'll certainly share them with the folks organizing the HR1 meeting and with the Secretary directly. Thank you.
And because Rebecca's question was so lengthy and enjoyable, we are at a point where I'd like to ask for a motion to adjourn.
Seems like everyone wants to stay, Matt.
All right, we can hang out a little bit.
This is Pam Walls. I'll make a motion to adjourn.
Thank you, Pam. We are adjourned. We will see you on July 1st. Take care, everybody.
It's 13 hours.
Get in my car and drive to college.